Hello students, today we will start shoulder joint which is a very important topic in upper limb, and it is the joint between the head of the humerus and glenoid cavity. So here we can see a coronal section taken through the shoulder joint to expose the articular features and other structures around the shoulder joint. So the shoulder joint is the most movable joint in the body. So when you move the shoulder joint, you can move up till 180 degrees. No other joint in the body as movable as shoulder joint normally. And consequently, it is least stable joint. Because if you see here, this is the head of the humerus. And this from here to here, I am drawing a line. This is the glenoid cavity. So glenoid cavity is a part of scapula, and head of the humerus is part of the upper end of the humerus. So these two parts, if you see, the head of the humerus is quite larger when compared to the size of the glenoid cavity. So that is the reason it is often prone for dislocations. So it is very less stable joint, and it is the most common joint to dislocate and to undergo recurrent dislocations. So it is clinically a very important joint which is often undergoes for recurrent dislocations. That is the reason it is important to know its anatomy of the joint. So it is important for you all students, which you have to must read it very thoroughly. So starting with the type of the joint, it is a synovial variety because it is movable. So it is synovial joint. Under synovial, one you can see head of the humerus forming the ball, and glenoid cavity forms the socket. So it is ball and socket joint. So if you see the articular surfaces, the medial articular surface is formed by the glenoid cavity. So the medial articular surface is formed by the glenoid cavity, and lateral articular surface is formed by the head of the humerus. And this articulation is known as glenohumeral articulation. Let's see the ligaments associated with the joints. So any synovial joint, it is surrounded by the capsule. So it is made up of a fibrous capsule. So this is also a synovial joint. So it is also has capsule. This capsular ligament is attached medially to the margins of the glenoid cavity. So here we can see the attachments of the glenoid cavity. I am drawing a black line. So this is the capsule. So the capsular ligament attaches medially to the margins of the glenoid cavity, and laterally it attaches to the anatomic neck of the humerus. So here is the anatomical neck of the humerus. So this is the anatomical neck of the humerus where I am drawing. So the laterally it attaches along the anatomical neck of the humerus. And if we see this capsule, it is deficient superiorly because we can see a tendon here. This is the long head of biceps. Biceps 𝐒𝐽𝐸𝐽. So it is deficient superiorly because we can see the long head of biceps 𝐒𝐽𝐸𝐽 passes through the piercing the capsule. It enters into the joint where it lies in a sulcus called as bicipital groove or intertubercular sulcus. So inferiorly, if we see, the capsule is loose because it extends till the surgical neck of the humerus. So you can see here, till here it is extending. So this is the surgical neck of humerus, and it is reinforced by the muscles forms a cuff around it called as rotator cuff. So the capsule is strengthened by the muscles. Here we can see the several muscles are there. They all forms a cuff around the joint which is called as musculotendinous cuff or rotator cuff. And capsule encloses the long head of tendon of biceps within the joint cavity, just we saw earlier. Next we shall talk about the ligaments associated with the shoulder joint. First is the glenohumeral ligament. It is the 3 thickenings of the anterior part of the fibrous capsule. So deep to the capsule, these glenohumeral ligaments are present, which are also nothing but the thickening of the fibrous capsule itself, and they are divided into 3 superior, middle and inferior glenohumeral ligaments. So this is the greater tubercle. So from here to the glenohumeral, so this is the superior glenohumeral ligament. Here is the middle glenohumeral ligament, and down one will be the inferior glenohumeral ligaments. Superior, this is the middle glenohumeral, and this is the inferior. So I am writing glenohumeral as GH. So defects, if we see these glenohumeral ligaments, they are not continuous. There is a gap between a superior and middle glenohumeral ligament. So I will show the gap. So between the superior and the middle glenohumeral ligament, there is a gap. There is a potential gap, and this gap is the weaker point of the capsule because it is defect between the superior and middle glenohumeral ligaments, and which acquires importance for anterior dislocation of shoulder joint. So as it is weaker here, so anterior dislocations occurs because of the gap between the superior and middle glenohumeral ligaments. Next ligament is the glenoid labrum. The glenoid labrum, as we know, the glenoid cavity of the scapula is shallow. It is not deeper like a concave cup. It is a shallow depression. So to increase the depth of the glenoid cavity, there is a fibrocartilaginous rim which is covering along the margins of the glenoid cavity. So if we see, there is a fibrocartilaginous rim which is present along the margins of the glenoid cavity. So this fibrocartilaginous rim is called as glenoid labrum. So this is glenoid labrum. So glenoid labrum is made up of white fibrocartilages. So the next ligament is the coracohumeral ligament. Coracohumeral ligament, it is attached from the root of the coracoid process. So this is the root of the coracoid process. It extends till the neck of the humerus. So it extends till the neck of the humerus. This is called as coracohumeral ligament. So this is the coracohumeral ligament, and which goes attaches to the neck of the humerus opposite to the greater tuberosity. Next is transverse humeral ligament. I will show you all. This is the transverse humeral ligament. Transverse humeral ligament extends between the lesser and the greater tuberosities. So this is the lesser, this is the greater tuberosity. I'll just put a direction. This is the greater tuberosity. This is the lesser tuberosity. In between the sulcus is the intertubercular sulcus, which is bridged. The groove is bridged by the transverse humeral ligament, enclosing a tendon. It holds the tendon of long head of biceps. So we can see the tendon of long head of biceps within the bicipital groove. Biceps tendon. To be specific, it is the long head of biceps. Next, coracoacromial arch. It is actually not connected between the humerus and the scapula. It is between the two processes of the scapula itself. That is between the coracoid process. We know this is the coracoid process and this is the acromion process. So the arch which is present here is the coracoacromial arch. So the coracoacromial arch, it forms like a secondary socket for the glenohumeral joint, preventing the upward dislocation of the head of the humerus. So it prevents the superior dislocation of the head of the humerus, forming a secondary socket for the glenohumeral joint. Next is the 𝗠𝐴𝐴𝐵𝐶𝐴𝐵𝐿𝐴R ligament. That is, it is between the coracoid process and the clavicle. So, coracoClavicular ligament extends between the coracoid process to the clavicle and consists of trapezoid and conoid parts. So, when it attaches to the rough part of the inferior surface of the lateral part of the clavicle, where the ligament is further divided into trapezoid and conoid parts. So, this ligament is also not in direct connection with the scapula and the humerus, but it is associated with the shoulder joint. So, continuing with the relations of the shoulder joint, superiorly it is related to coracoacromial arch. And it is related to the subacromial bursa. So, below it, the bursa, this blue color is the and then it is related to the supraspinatus and deltoid. So, this is the supraspinatus muscle, supraspinatus, and also this fully thing is covered by the deltoid. So, deltoid is removed to expose the shoulder joint. So, this is the deltoid. So, these are the superior relations. So, inferiorly it is related to the long head of triceps. So, I am just representing here the long head of triceps. Inferiorly it is related to the long head of triceps. So, this is the long head of triceps I have just shown as a representation. Along with the long head, it is inferiorly related to the posterior circumflex humeral vessels, so which are the arteries running along the surgical neck of the humerus. This is posterior circumflex humeral vessels, and it is related to the axillary nerve. So, I am drawing nerve with green color, which is winding round the surgical neck of the humerus. This is axillary nerve. So, these are the inferior relations of the shoulder joint. Anteriorly, it is related to the anterior fibers of the deltoid, coracobrachialis, short head of biceps brachii and subscapularis. So, these are the anterior fibers of deltoid is removed. So, anteriorly deltoid is related, and it is related to the coracobrachialis, a small muscle which runs toward from the coracoid process to the neck. So, I am just drawing a line. So, this is coracobrachialis, and it is related to the short head of biceps. So, along with the coracobrachialis, the muscle which gets origin is the short head of biceps, and it is also related to subscapularis. So, this muscle is the, so more deeply is the subscapularis. In front of it is the coracobrachialis and short head of biceps, and still more it is covered by the anterior fibers of deltoid. So, these are the anterior relations of the shoulder joint. Then moving on to the posterior relations. Posteriorly, it is related to the posterior fibers of deltoid. So, this is the posterior fibers of deltoid. And after removing the posterior fibers of deltoid, on posteriorly, we can see it is related to infraspinatus. So, this is infraspinatus muscle. And along with the infraspinatus, we can see teres minor also. So, these are the posterior relations to the shoulder joint. So, we are discussing that the shoulder joint is highly unstable joint. So, the factors which provides the stability to the shoulder joint are, one is the musculotendinous cuff. It is formed by the muscles which are inserted to the greater tuberosity and lesser tuberosity. So before inserting into the greater and lesser tubercles, the muscles, they form a sheet around the joint along with the capsule called as musculotendinous cuff. So musculotendinous cuff, from the posterior side, it is formed by the supraspinatus. So we can see it is forming here like a sheath. This is the rotator cuff or musculotendinous cuff. And it is related to the infraspinatus. Musculotendinous cuff is formed by the infraspinatus teres minor. From the anterior side, musculotendinous cuff is formed by the subscapularis. So here is the anteriorly. This is subscapularis. It is present underneath the scapula. So it is called subscapularis muscle. So that is about the musculotendinous cuff. Okay, the next factor which provides stability to the shoulder joint is the coracoacromial arch. So here is the coracoacromial arch which I have already labeled. So this forms the secondary socket. So it is otherwise called as secondary socket for the head of the humerus. And it protects the joint from above and prevents upward dislocation of the head of the humerus. The next factor which provides stability to the shoulder joint is the glenoid labrum. So already we have discussed the glenoid labrum, which surrounds the rim of the glenoid cavity and deepens the glenoid cavity. The muscles which are attaching from the pectoral girdle to the humerus, they also protect the shoulder joint. And lastly, the atmospheric pressure also maintains the stability of the shoulder joint. So within the joint, there is a tendon called long head of biceps. So within the joint, there is a long head of biceps tendon, and this tendon passes above the head of the humerus in a intracapsular, hence prevents it upward displacement. The superior displacement is prevented because of the tendon of biceps, which also is a factor which provides the stability to the shoulder joint. So next we shall see the bursa associated with the shoulder joint. The bursa around the shoulder joint are clinically important as some of them communicate with the synovial cavity of the joint. So what are these bursa? Bursa means they are like fluid filled pockets. They are like cushions which are filled with the fluid, that is the synovial fluid, and present around the joints, and it prevents the friction. So it reduces the friction around the joint. Usually the bursa are present around the joint and they are present between the tendons surrounding the joint. So there are several bursa related to the shoulder joint, but the important ones are subacromial bursa. Means it is below the acromion process. So this is the subacromial bursa, and it lies between the acromial arch and supraspinatus muscle. So we can see this is the supraspinatus muscle. So above it is related to coracoacromial arch and below it is related to the supraspinatus muscle. It protects the supraspinatus tendon against friction with the acromion process. Next is the subdeltoid bursa. It lies between the deltoid muscle and the shoulder joint. So this is the deltoid, we already know. So this is the subdeltoid bursa, as it lies between the deltoid and the shoulder joint. Usually it communicates with the subacromial bursa and facilitates the movement of the deltoid muscle over the joint capsule and the supraspinatus tendon. Next is the subscapularis bursa. It lies between the tendon of the subscapularis. So here in this picture we can see the subscapularis muscle. If we reflect the subscapularis muscle, we can see the subscapularis bursa. It is present between the neck of the scapula, that is just near to the glenoid cavity of the scapula, and to the subscapularis muscle. Anteriorly it is related. It protects the subscapularis tendon from friction against the neck of the scapula. And this bursa usually communicates with the joint cavity. So the next one is the infraspinatus bursa. It lies between the tendon of infraspinatus muscle and the posterior part of the joint capsule. So here the infraspinatus muscle is here. What is shown, this is the deltoid bursa, subdeltoid bursa, which is present between the deltoid and the joint cavity. So infraspinatus is, this is the infraspinatus muscle. So the bursa is related just below the infraspinatus muscle like this. This is sub-infraspinatus bursa. So it lies between the tendon of infraspinatus and posterolateral part of the joint capsule. So here is the anterior side of the joint. This is the posterior side of the joint. So this is a sagittal section through the joint where they remove the head of the humerus to show the glenoid cavity and structures around the glenoid cavity and the shoulder joint. So here is the sub-infraspinatus bursa which lies posterolateral aspect to the joint capsule. It may sometimes communicate with the joint cavity. So these are the important bursae which are related to the shoulder joint. Next we shall talk about the blood supply of the shoulder joint. Shoulder joint is supplied by anterior and posterior circumflex arteries. So anterior and posterior circumflex humeral arteries. So these humeral arteries which surround the surgical neck of the humerus, branches of axillary artery which also gives blood supply to the shoulder joint. So circumflex arteries. Next is the suprascapular artery which runs along with the suprascapular nerve to supply the supraspinatus and infraspinatus muscle. So suprascapular artery from above. So I will just mention here suprascapular artery. The next artery is the subscapularis artery which supplies from below along with the subscapularis, subscapular artery. So these are the arteries which supply the shoulder joint. Nerve supply to the shoulder joint. We know that the surgical neck of the humerus, it is winded round by the axillary nerve. So the axillary nerve which winds round the surgical neck, it gives articular twigs to supply the shoulder joint. And not only the axillary nerve, musculocutaneous nerve, suprascapular nerve and lateral pectoral nerve also supply the shoulder joint. So along with the axillary nerve, the other nerves are musculocutaneous nerves, lateral pectoral nerve and suprascapular nerve. So these nerves gives articular twigs to the shoulder joint. Movements of the shoulder joint. So the first movement is the flexion. So the anterior muscles of the shoulder joint helps in the flexion of the shoulder joint. So the anterior fibers of deltoid, then the clavicular head of pectoralis major. So from here till here is the clavicular origin. So these are the muscles are primarily helps in the flexion of the shoulder joint. Apart from these muscles, it is also aided by coracobrachialis muscle. So the coracobrachialis is present on the medial side. Along with the coracobrachialis muscle, even the short head of biceps. So these are the accessory muscles which helps in the flexion of the shoulder joint. So next about the extension of the shoulder joint. Extension is brought by the posterior side muscle fibers, that is the posterior fibers of deltoid. So posterior fibers of deltoid and long latissimus dorsi. So this is and remember one thing, latissimus dorsi is the only muscle which connects the lower limb bones with the upper limb. So it is having connections with the hip bone down and it also gets inserted to the humerus, that is the bicipital groove of the humerus. So that is the importance of the latissimus dorsi which also helps in extension. And apart from these two muscles, long head of triceps brachii. So here is the triceps long head. Because long head of the triceps brachii gets origin from the scapula and it crosses the shoulder joint. So it aids the extension of the shoulder joint. And teres major muscle. So here is the teres major muscle. So these are the muscles which helps in the extension. So the primary extensors are posterior fibers of the deltoid. So posterior fibers of the deltoid, and apart from that it is also aided by the latissimus dorsi. These two are the primary muscles, and the accessory muscles are the long head of triceps and teres major. Adduction is brought by the pectoralis major and latissimus dorsi. So one from the anterior, one from the posterior. So latissimus dorsi is here and pectoralis major muscle is present on the anterior side. So pectoralis major and latissimus dorsi helps in adduction. Means bringing the arm towards the body is the adduction. And the accessory muscles are teres major from the posterior side and coracobrachialis from the anterior side. Next, about the abduction. Abduction of the shoulder joint, initial 15 degrees of abduction is brought by the supraspinatus. So here is the supraspinatus. So initiation of the abduction, that is initial 15 degrees of abduction is by the supraspinatus. Beyond 15 degrees, it is brought by the middle fibers of the deltoid, that is the acromial fibers, means the middle part of the deltoid. That is 15 to 90 degrees. Beyond 90 degrees, that is overhead abduction. And what happens in overhead abduction? Along with the head of the humerus, even the scapula also rotates upwards. That is called as scapulohumeral rhythm. So beyond 90 degrees, that is 90 to 180 degrees, the movement of the scapula is because of serratus anterior and trapezius muscle. So this is trapezius, which is the superficial muscle on the neck, and the serratus anterior muscle. If we remove all these things, the deeper muscle will be the serratus anterior, which is present on each side of the ribs, getting origin from the as 8 digitations from 8 ribs. Next, about the medial rotation. Medial rotation of the shoulder joint, it is brought by the pectoralis major muscle. So from anteriorly pectoralis major muscle and latissimus dorsi from the posterior aspect, anterior fibers of deltoid again from the anterior, and teres major from the posterior. So one anterior, one posterior, you have to remember. Pectoralis major, latissimus dorsi. Anterior fibers of deltoid, teres major. And accessory muscle of medial rotation is subscapularis muscle. Next, about the lateral rotation. Lateral rotation is brought by the posterior fibers of deltoid. So here is the posterior fibers of deltoid. So lateral rotation is by the posterior fibers of deltoid, infraspinatus muscle. So this is infraspinatus muscle, and also by the teres minor muscle. So these posterior muscles will help in the lateral rotation of the shoulder joint. So these three are primary muscles which helps in the lateral rotation. Next, we will talk little more about shoulder abduction. The total range of shoulder abduction is 180 degrees. That is a very wide range of movement, right? And abduction up to 90 degrees, that is initial 90 degrees, it occurs at the shoulder joint level itself. Further 90 to 120, it occurs as the humerus is rotated laterally. That is, the scapula also starts rotating laterally. That is 120 to 180 range. It is added by the lateral rotation of the scapula. So this lateral rotation of the scapula along with the humerus is called as scapulohumeral rhythm. So if we see the abduction, supraspinatus initiates the abduction and causes initial 15 degrees of abduction. And deltoid is the main abductor from 15 degrees to 90 degrees of abduction. It is sequentially by the humerus and is laterally rotated by the infraspinatus and teres minor muscle. And the next overhead abduction, that is 90 to 180, it is carried out by two muscles mainly, that is trapezius and serratus anterior muscle. So during abduction, trapezius and serratus anterior cause lateral rotation of the scapula and glenoid cavity eventually faces upwards. So scapula also rotates along with the head of the humerus, the scapula also rotates. Abduction of the shoulder involves the rotation of the clavicle also in its longitudinal axis, which occurs at both the sternoclavicular and acromyoclavicular joints. And this contributes about 60 degrees of rotation of the clavicle in total. So this is all about the abduction of shoulder joint. So remember, initial 15 degrees it is brought by what muscle? Supraspinatus. So if there is any supraspinatus tendinitis, the person will have difficulty to initiate abduction. So if we help for 15 degrees, if you lift, then he can do up to 90 degrees because the deltoid muscle is active. So continuing with the clinical aspect of the shoulder joint, we all know now the dislocation of the shoulder joint is very common, and inferior and subglenoid dislocation endangers the axillary nerve, because if we know that axillary nerve is present inferior to the shoulder joint, and most common in anterior dislocation. So the anterior dislocation of shoulder joint is very common. So the next condition is shoulder tip pain. Irritation of diaphragm caused referred pain to the shoulder because supraclavicular nerves supplying the skin over the shoulder has the root value as C3, C4. So they have the root value as C3, C4, and if you see the root value of the phrenic nerve which supplies the diaphragm, it is also C3, C4 and C5. So irritation of the diaphragm, the pain will be referred to the tip of the shoulder because the same root value nerves are supplying the tip of the shoulder via the supraclavicular nerves. And this is phrenic nerve. This is the root value of phrenic nerve. So that is a very important clinical aspect associated with shoulder joint. And next is the frozen shoulder, which is also known as adhesive capsulitis. So chronic periarthritis of shoulder will result in frozen shoulder or adhesive capsulitis. It is a clinical condition characterized by the pain and uniform limitation of all the movements. So the person will have especially difficulty to comb their hair and to do overhead abduction. All these movements are restricted because the capsule of the shoulder joint gets thickened and becomes adhesive. So they start sticking with each other. That is called as adhesive capsulitis or frozen shoulder. So though there is no radiological changes in the joint, it occurs due to shrinkage of the joint capsule, and hence the name adhesive capsulitis. And this condition is generally seen in the individuals with 40 to 60 years of age, and especially it is seen more in females than in males because females won't do overhead abduction often. So this completes the shoulder joint. Thank you.